Dr. Mahmoud.
Thank you very much for having me. I always like to go after the surgeon, not before, so this is, you guys changed things on me, but hopefully this will be a case that kind of generates a lot of discussion in the audience. So we'll jump straight into it. This is an 83-year-old male who presented to an outside hospital with progressive respiratory distress over 4 days, found to be in pulmonary edema, basically heart failure. EKG showed acute posterolateral ST depressions. He was taken to the cath lab at the outside hospital, found to have 3-vessel disease, left main 40%, tight osteo and mid-LAD. Circ was 90% prox, occluded mid, and occluded right with well-formed collaterals. So he was transferred to our hospital for consideration of CABG. However, he came pretty late at night. Upon transfer, he remained in shock, needed a balloon pump, and posterior ST depressions, and so he was taken to the cath lab urgently. So this is baseline angiogram after putting in the balloon pump. As you can see, just a heavily calcified circ, occluded, some minimal flow distally. You can see collaterals to the right. Sorry, the pictures are jumping ahead. And then on this view, you can see that focal proximate LAD lesion. So I think at this point was, you know, there's a few ways to go.
Can we go to the poll, please? Hussam, can you put the poll, please? So now we know the case, how is it went through. Please show us what do you think is the best treatment option.
That's the wrong question, guys.
The other one, the one before. First question, Shabab.
First, before this.
اللي قبلها.
You guys are giving away the story now, guys.
The one before that, please. Okay, so everyone should just pull up their cell phones and pick what do you think.
This is the wrong question.
يا شباب لا حول ولا قوة إلا بالله. There's no point. Okay.
Just go back to the slides. Just go back to the slides. We'll discuss it.
There you go.
Okay, so, I mean, our options at this point is try to stabilize the patient further, maybe put in an Impella, upgrade, get an echo, and plan for bypass surgery with the severe 3-vessel disease. Attempt to open the circ, or try to do multi-vessel revascularization. I didn't show you the RCA, but it was a long CTO. Or to attempt to open the circ and the LAD.
So we'll give I would like while people are plotting their answers, I would like to go through. So Dr. Adel Tash, what do you think? Should we, from the options that are presented from the anatomy, have you seen a patient in shock? Would you take this patient for an urgent CABG?
That's a good question. I think I would try to stabilize the patient and do a CABG, yes.
Okay, so give it some time, stabilize the patient, and then maybe considering for CABG for this patient. Dr. Fahad, what do you think?
So I agree with revascularization. Just go and fix the coronary before going for further assessment. So I will just go with revascularization, then assess the mitral.
Okay. So since this room is full of interventionists, I think most of them are voting, like 63%, to go and open the vessels. So what happened next, Dr. Traina?
And everybody's voting for complete in spite of the evidence.
Complete revascularization.
So, which is interesting in spite of the culprit shock data. So they tried a lot on the circ, and they used, I don't show all the pictures.
Back to the slides, please.
Oh, sorry, yeah. I see them on my computer. So they were unable to, I don't know why it's doing that. But they were unable to cross the circ after multiple attempts, and so they went ahead and treated the LAD at this point. And they left the circ thinking that it's more of a chronic lesion than we expected, and the ST depressions were from chronic ischemia. So after that, the patient remained in shock, on balloon pump dependent, dopamine, norepinephrine drip. So we did get an echo the next day. His EF was, and next morning, EF was 32%. Had wall motion abnormalities in all 3 territories, and severe low flow, low gradient aortic stenosis. Valve area was 0.8, dimensionless index of 0.24, mean gradient of 24, and severe mitral regurgitation with an ERO of 0.4. And the echo was done while on intra-aortic balloon pump support. And over the next couple of days, patient remained in shock and unable to wean the balloon pump. So I'm sorry, Zakaria, I don't have too many pictures for you. I know you like pictures, but I just showed a couple of pictures of the aortic valve here just to see show it's calcified. And here just the severe mitral regurgitation, and then the severely reduced LV function here. The TE was also performed that same day, showing the severe MR, and it actually worsened when the balloon pump was placed on standby or at 1 to 2. And just a severe functional restricted posterior leaflet, central MR jet.
So let's hold the poll,
One
please.
more, so just as to complete the workup, we decided to do a CT TAVR protocol. And in those findings, no, before we go to the poll still. 1 second, let me just show the CT findings, and then we'll do the poll. Can you go back? Yeah, so the CT showed calcium score was not sky high. The planimetry was 0.9. Annulus measured on the small side. Good SOV, good STJ, good coronary heights, and good femorals and iliacs. Okay, so now we can show the poll. So at this point, what do we do? So patient has basically persistent, not progressive shock, but refractory shock. Requiring still balloon pump and inotropes dependent. So do we continue with medical therapy, maybe upgrade the support device, hope for stabilization? Do we consider high-risk surgery now at this time, also on DAPT? Do we just fix the aortic valve? Do we just fix the mitral valve?
So
percutaneously
I will take
or
it with the
combination?
panelists here, Mahmoud. Dr. McKinson, what are your thoughts? You see the images, you know they're fixed already, the vessels.
Well, I think given the situation of the patient now in shock for several days, it's really important to quickly act. I can only imagine the complications with other organs, kidney and so forth. So to me, I think the aortic valve would come first. But if the patient is stable enough after TAVR, there's no reason not to consider a mitral tear as well. Looks like the leaflets are amenable to that. I didn't really see the volume of the LV and the left atrium. I think the patient is in sinus rhythm, so probably more a functional secondary MR rather than atrial MR. But certainly, I think doing both is absolutely a possibility.
Okay. Anas, any thoughts?
Yeah, I totally agree. The valve lesion that most likely will impact the patient's outcome in this extreme state would be the aortic valve, but if the patient continues to have significant mitral regurgitation after doing the TAVR and the patient is hemodynamically stable, as long as we don't introduce MS, I think it's reasonable, given the fact that the patient is in cardiogenic shock, to attempt to reduce that mitral regurgitation with edge-to-edge repair.
And Dr. Zakaria, since your procedural analysis, so the voting is going to do TAVR, but plus minus a tear, possible during the same setting or out. None, like very few have mentioned to go for high-risk CABG. From imaging perspective, what is your thought and procedure?
So we know that the LV function is
Smart
severely
screen,
reduced. It is ejection fraction 32%, and has already regional wall motion abnormality in the LAD, circ, and also in the RCA area. So we know that the chance of recovery of this of the posterior mitral valve tethering because of the regionality will be very low, because already the circ is occluded and it was not revascularized. So the chance of resolution of the MR will be very low. Usually, when in the presence of severe aortic stenosis, we'll recommend to do the aortic valve first and to wait. Probably the MR will reduce later on. But in the presence of this occluded circ, regionality in the circ area, tethering of the posterior mitral valve leaflet, you would know that it's unlikely to resolve the MR. So it's better to go for both aortic first and then the mitral, like Dr. Bachert mentioned.
Dr. Traina. So we can go back to the slide. So we have like kind of a consensus here with everyone that you go for percutaneous option in terms of the valves. going with TAVR first, your CT looked very amenable, and then figure out the mitral. So what has been done for this case? Back to the slides, please.
All right, so yeah, so our team agreement was similar. So we felt the mitral regurg was the main physiologic problem, but fixing it without treating the aortic valve at this time would be a problem. So we planned for both with a decision tree after doing the TAVR. Sorry, I don't know why the slides keep going ahead by themselves. So the TAVR went straight forward with the sapien valve, 23. No leak on the TE images. Patient was obviously intubated at this time, and so we tried to get away with minimal contrast, given that he did have already some signs of AKI, as you mentioned. And then this is the TE after the TAVR. So the left is with the balloon pump going, the right is with the balloon pump on standby, and so it looked like it didn't improve.
Let's have the poll again, please. So while we put the poll in the stadium and we see, so we fixed the aortic valve. The next question, please, number 3. So we fixed the aortic valve. Now the
Next question. Yeah.
burden question now, should you proceed in the same setting or in the index on the table to mitral tear, or you're going to wait and see maybe in hopes that the MR, well, Zakaria told us his insight that he doesn't think this MR will go away, but I would like to hear from the panelists while the people applaud their answer. Dr. Fahad?
It's difficult to tell which one is causing the cardiogenic shock or refractory shock. Is it the aortic valve? Is it the mitral? Is it the coronary? We don't have like enough evidence which one is causing. I think maybe right heart cath may guide us on if we need to proceed with the mitral clip. So I think there was a Swan-Ganz during the prior procedure. If we have the number, probably will help us. But stabilizing the patient, diaries, reassess with the Swan-Ganz, and then we decide about the mitral clip. So I think we need more data.
So you're saying like having hemodynamics will support either to proceed or postpone.
Yeah.
Dr. Adel Tash, if I called you now on the table, told you I finished the TAVR, patient still in shock, you would consider taking him for repair, for example, or what are you going to tell me? What do you want to know more?
Well, I think from the start, the culprit for the cardiogenic shock is the coronaries, the myocardium, and the sequel of a severe MR. So probably fixing the aortic valve was not addressing the culprit. And I would just step back. I would definitely, if we cannot address the coronaries intervention, we need to address it surgically. And to fix the mitral valve and do the complete job. But now, with this, no, I definitely would go for the clip at the same setting. Otherwise, the patient would still be on inotropic support and intra-aortic balloon pump.
Okay, so yes, Dr. McKinnon.
Just one quick comment. Now that the TAVI has been done, I think we don't have to be too concerned about the ventricle on the left side with fixing the MR and taking that away. So I think timing is good here and should help the patient further to increase cardiac output.
Mm-hmm. Anas, any last thoughts before we know the final end of the story?
Yeah, in this setting, time is of the essence. This patient is in cardiogenic shock. So in another case, I would have waited, but since this patient is in cardiogenic shock and we still have significant MR, I would just proceed with edge-to-edge repair. Yeah.
Okay,
Yeah.
so let us see. Back to the slides, please. So let's see the final end. How
Great.
things
So we did. So he did have a right heart cath. I didn't include the numbers, but when we put the balloon pump on standby, the V waves got bigger. Also, along with the color on the pictures. So we did decide to proceed. I didn't show again all the technical issues. This is more of a case to discuss the approach. But one clip, single, slightly medial with trace residual MR after the case. Final gradients on the mitral valve were 4 because it was a relatively small valve, and aortic mean gradient was 9. So, and no leak on the aortic valve, looked all good. So as these sick old people do to you, they humble you because, you know, we patted ourselves on the back, patient's doing great, the balloon pump was removed the following day, the pressors were weaned, he was extubated, then he goes into septic shock on day 4. reintubated, has trouble getting off the ventilator, and spent, I think, 4 to 5 weeks total in the hospital after that. So, you know, sometimes you do all you can, and then they take a step back. But he survived. He did survive.
He survived and he was discharged from the hospital eventually, correct?
Yes.
So congratulations. It was an amazing effort from everyone in the hospital. Do we have any questions from the